Welcome everyone to this webinar from the Royal Belgian Society of Dermatology. This session will be about autoimmune bullous disease. First of all, I would like to thank all our sponsors. Thank you for making this evening possible. You can add your question during any presentation to the chat box below the screen, and we will present them regularly during this session. Let's go to the heart of the matter. It's an honor to have with us tonight Professor Enno Schmidt from Lübeck. He has been a great expert in this field for many years. Thank you, Professor Schmidt, for being with us tonight. The first part of this session will be about the diagnosis of autoimmune bullous disease. It's my pleasure to introduce Professor Enno Schmidt, who is Professor and Director of the Lübeck Institute of Experimental Dermatology at the University of Lübeck. His main contribution tonight will be about his diagnostic algorithm. The floor is yours, Professor Schmidt.
Yes, thank you very much for this nice introduction. I try to share my screen and then we should be ready. And it's my great pleasure. Let's see, it's my great pleasure tonight to be invited by the Belgian Society of Dermatology to share my thoughts and our algorithms for the diagnosis of autoimmune blistering diseases. And these are my disclosures here. And as you may know, one can broadly categorize the group of autoimmune blistering diseases that comprise about a dozen entities in three groups. The first is the pemphigus diseases characterized by autoantibodies against desmosomal proteins and intraepithelial split formation. The second group is the pemphigoid group, and here the by far most frequent autoimmune blistering disease is bullous pemphigoid. It's twice as frequent as all the other autoimmune blistering diseases taken together. And the pemphigoid group is characterized by subepidermal splitting and autoantibodies against structural proteins of the dermal epidermal junction. And then we have dermatitis septiformis. Here the autoantibodies are directed against two enzymes, transglutaminase 2 and 3. And the diagnosis is really set on 4 columns. And maybe an old column, but maybe the weakest today is histopathology. And that is still important. And we still encourage to take lesional biopsies for histopathology in all patients, because if serology and direct fluorescence are negative, then histopathology is essential to assess and evaluate further differential diagnosis. So really important is the clinical picture. So if you do not know the clinical pictures in some of these entities, you cannot make the right diagnosis. For example, paraneoplastic pemphigus requires a malignancy, or you cannot diagnose pemphigoid gestationis in a patient that is not pregnant, or in a male patient, of course. And in mucous membrane pemphigoid, by definition, you need predominant mucosal involvement. And yes, dermatitis septiformis, that is the cutaneous manifestation of celiac disease. So you need also celiac disease to be present. Having that in mind, the diagnostic gold standard is still the direct fluorescence of a per-lesional biopsy. So in every patient with suspicion of autoimmune blistering diseases, a per-lesional biopsy is required. And here you can see 3 patterns. I mean, the first one is the pemphigus pattern here on the left. Yes, this typical rete-like intercellular deposits of IgG and RC3 in the epithelium. For pemphigoid diseases, the linear binding of IgG, IgA, or C3 at the dermal epidermal junction is characteristic. And in dermatitis septiformis, you can make the diagnosis when you see granular IgA deposits either along the basal membrane zone or in the dermal papilla. So, for example, If you see this picture here under the microscope, IgG or C3 linear at the dermal epithelial junction, you can already exclude, of course, the pemphigus diseases. You can exclude dermatitis epiformis, and because there's no IgA, you can exclude linear IgA disease. So you're then stuck with these 5 diagnoses here. And the question now is, can you actually come one step further, only looking to this picture here? And yes, you can. This has been described nearly 20 years ago by the colleagues from Groningen. And they discovered that in pemphigoid diseases, the linear deposits are not really linear, but they're slightly undulated. And there you can differentiate 2 patterns: the anse-serrated pattern with arches closed at the bottom, and then the U-serrated pattern, with arches closed at the top. And then you have the U-serrated pattern with arches closed at the bottom that looks like growing grass. And the U-serrated pattern is really pathognomonic for autoantibodies against type 7 collagen, meaning epidermolysis bullosa acquisitor. And that is something that is relatively easy to learn, this assessment. There's an online training tools by the Groningen colleagues. You just need a normal immunofluorescence microscope. There's no special storage media required, and also a 400 or 600 magnification is sufficient, so there's no oil necessary. And Michael Holter from our clinic investigated more than 300 consecutive biopsies from pemphigoid patients, and she has shown 2 things. First, and both in retrospective and prospective cohorts, about 4% of the samples showed the U-serrated pattern corresponding to epidermolysis bullosa acquisita, and about a quarter of these samples, there the diagnosis, anse-serrated or U-serrated pattern, was not possible, so that was undetermined. But importantly, for the U-serrated pattern, there's a very high sensitivity. So none of the U-serrated pattern biopsies in these patients could other antibodies, in addition to type 7 collagen, be found. And also the specificity was relatively high, because in none of the undetermined patients, autoantibodies against type 7 collagen could be found in the serum. So that is a valuable method that can be used in the routine diagnosis for pemphigoid diseases. So to summarize this part, so you need a perilesional biopsy for direct immunofluorescence. Okay, if you have intercellular immunorectance, then it's pemphigus. If it's granular IgA, you have dermatitis epiformis. And if you have linear IgG, C3, or IgA, then you should do the serration pattern analysis. And if it's anse-serrated, then you have either bullous pemphigoid, pemphigus gestationis, antipterin pemphigoid, or if it's IgA linked, then linear IgA disease. If it's predominant mucosal lesions, you have mucous membrane pemphigoid. And if it's an U-serrated pattern, okay, you still have MMP if there are predominant mucosal lesions, or you have, it's predominant IgG, epidermolysis bullosa acquisitor, or very rarely bullous SLE. And if it's IgA, then IgA-EBA. Here, this is an interesting case. If your initial biopsy is negative, then of course you have the possibility that it's no autoimmune blistering disease. But this is highly recommended if you're in doubt and if you have high clinical suspicion, then you need to repeat that. And if the suspicion is for MMP, for mucous membrane pemphigoid, then you should at least repeat it twice. But we come to that later, so you need 2 additional biopsies. Here's 3 cases from our clinic analyzed by Katharina Boch. They show some kind of unspecific erythema, itchy, purple, slightly excoriated. And in histopathology, nothing really special, some lymphocytes here, some eosinophils in the upper dermis. But then there is an interesting part, because when we did direct immunofluorescence, you saw linear binding of IgM at the dermal epidermal junction, and that was nearly exclusively IgM, so no IgG and only no IgA and only a very weak C3 in one patient. And then we also looked for the sera of these patients, and in all of these 3 patients, we found IgM antibodies against different recombinant forms of BP180, the main target antigen in bullous pemphigoid. So we think that this, and propose this term here, this is something we call IgM pemphigoid. And now we try to find out this is something specific. And this is something we have now submitted. There are 10 more patients, and most of them have the same clinical picture: no frank blistering erythematous lesions, some excoriations, and very itchy, unspecific histopathology, and exclusively IgM antibodies by direct immunofluorescence, and here also in salt split skin. So we ask for everybody to look for that and collect more cases to see if that is a real novel entity or not. Okay, the third column, diagnostic column, is serology. And that is something that has really been developing in the last 2 decades. And that is really based on the molecular identification of the target antigens. And so far, we can say that if you know the clinic, then you can do the serological diagnosis in more than 90% of the patients. And I show you some examples here. I mean, we do still do the screening in all patients on monkey esophagus, and then in pemphigus, we have this typical rete-like intercellular pattern in the monkey epithelium. Here's the lumen. And then, of course, for dermatitis herpetiformis, you see IgA reactivity and the endomusium. And also for all patients with autoimmune blistering diseases, we subject them to indirect immunofluorescence on human salt split skin. And there you have 2 patterns. Either you have linear binding at the epidermal site, at the blister roof, and this is the artificial blister. And this occurs with antibodies against BB180 and BB230. And the second possibility is, of course, the linear binding at the blister floor. That occurs in autoantibodies against lamin 52. We come to that in a minute. The P200 protein, we also come to that. And in type 7 collagen reactivity that we find in epidermalized bullosa acquisita. And this is just an overview of the target antigens in pemphigus here, a little bit on the left, and here in the dermal epidermal junction for the pemphigoid diseases. And since that is known, then recombinant fragments of these proteins can be applied in different assays. And there are 2 companies that provide highly sensitive and specific ELISA systems. Here, for example, for desmin 3, the main target in pemphigus vulgaris, desmin 1 for pemphigus foliaceus, and voplakine for paraneoplastic pemphigus, BB180 and C6A, as you know, for bullous pemphigoid, but also for pemphigoid gestationis and also for a portion of patients with mucous membrane pemphigoid. Then we have BB230 in 50 to 70% of the patients with bullous pemphigoid, and transglutaminase 2 IgA reactivity here in celiac disease and, of course, also in dermatitis herpetiformis. And these ELISA, they're very valuable for the diagnosis, but also in the follow-up of the patients, because most of these autoantibodies, except maybe for BB230 and voplakine, they correlate with disease activity. That is also helpful to monitor disease activity. And now I would like to introduce you to something that is a multivariant assay. So here you can simultaneously detect specificities against different target antigens based on the biochip technology. And here you have a normal lab slide with different incubation fields, and within one incubation fields, several miniature substrates, in this case 6, can be placed. And then if you incubate that, for example, here with the Pemphigus vulgaris serum, you have your monkey esophageal salt split skin and cells that express desmin-3, desmin-1, BB230, and recombinant BB180. You see here reactivity for the Pemphigus vulgaris serum with the monkey esophagus and desmin-3. So that is clearly Pemphigus vulgaris. And this is another example for Bullous pemphigoid. Here you see the basal membrane zone binding and reactivity with these diamonds. This is spotted recombinant BB180 and C16A, and also here with cells that express BB230. And here you already have quite a good overview. And by this has been shown already 10 years ago that if you know the clinical picture, 90%, more than 90% of the sera, you can already make the diagnosis. And this thing now has been used a lot worldwide. It's highly standardized, and it's helpful in many laboratories. The last minute I would really spend with two diseases, mucous membrane pemphigoid and NTP200 pemphigoid, to give you a little bit more detailed information here. For mucous membrane pemphigoid, the task force of the EDV has created, it was 2 or 3 years work, as 3 guidelines here published 2 years ago in GADV. And as I already said, mucous membrane pemphigoid is defined as a pemphigoid disease by predominant mucosal lesions. And then you also take a direct immunofluorescence from a perilesional biopsies. And if you then see here linear deposits of IgG, IgA, or C3, you can already make the diagnosis of mucous membrane pemphigoid. So, but why do you need, that's something I should also mention. I already said this, but I repeat this. So if you have the suspicion of mucous membrane pemphigoid and the initial direct immunofluorescence is negative, so the guideline recommends to take at least 2 additional biopsies from different mucosal sites to really exclude or diagnose the disease. So, but why do you need serology for? I mean, you already have the diagnosis here. I give you a very important example. I mean, in mucous membrane pemphigoid, you have 3 target antigens. So mostly it's BB180 here, but it can also be Lambert-52 or, in rare cases, type SAP collagen. And together with the company Loraine, Stephanie Golitz, and based on this biochip technology, has developed quite sensitive and very specific assay, immunofluorescence-based assay, using the Lambert-52 heterotrimer expressed in human cell line. And then it has been shown by us and also by others that 25% of the patients with anti-Lambert-52 reactivity, the mucous membrane pemphigoid patients, they have a malignancy. And as you can see here, by just a short selection, are mostly solid malignancies. And this is not only our data, these are data from different groups all over the world. And together with Dresden, we also had a retrospective study with more than 150 mucous membrane pemphigoid patients. And here we found that in the patients with anti-Lambert-52 reactivity, they had a 6.8-fold increased risk to develop a malignancy compared to the general population. So that is something that is real and that needs our attention. And also the guideline recommends that in all newly diagnosed patients with mucous membrane pemphigoid, you need to test for anti-Lambert-52 reactivity. I mean, there are a lot of in-house assays available in specialized laboratories, but here, this one I showed you, this is widely available. And now the last disease I would like to touch is anti-P200 pemphigoid. And this is the disease initially described by Delvaux and Takashi Hashimoto in 1996. And the patients, they look quite similar than Bullous pemphigoid, but there are two differences. There are more hands and feet involved, and usually they can be treated more easily, so need less immunosuppression. So it's important to differentiate this disease from both epidermolysis bullosa acquisita and Bullous pemphigoid. And here the autoantibodies, I shortly mentioned that, bind to the floor of the artificial skin on human soft-split skin, and they recognize a 200 kilodalton protein by Western blotting of human dermis, and that's why it's called P200 pemphigoid. And the incidence, there are a few data. We have data from northern Germany, so it's about 0.7 per million inhabitants per year. This is much less. Then it's 3 times less than pemphigus, but it's much more than, for example, epidermolysis bullosa acquisita. Epidermolysis bullosa acquisita, most of you will know. And now I think it's also time to recognize anti-P200 pemphigoid. And I give you one reason more in a minute. And then laminin gamma 1 has been described as target antigen of this disease, but only 17 to 90% of these patients have antibodies against laminin gamma 1, and we and others were unable to show a pathogenic relevance of anti-laminin gamma 1 antibodies in various in vitro and also in mouse models. And then now Stefanie Golitz and Manuela Pigors, they used immunoprecipitation of dermal extract, and then they discovered laminin beta 4, and if laminin beta 4 was expressed recombinantly, and here already the 7 first anti-P200 pemphigoid that we tested, they all reacted with laminin beta 4. And then in cooperation with Euroimmune and based on this biochip technology, there were human cell line expressing recombinant laminin beta 4, and then testing more than 200 anti-P200 pemphigoid sera, only 2 of them were unreactive with laminin beta 4, and the specificity, nearly 500 control sera, was also very high. So we can say that laminin beta 4, that is still unpublished, so it's not that frequent that I have already talked about it. This is the diagnostically relevant target antigen for anti-P200 pemphigoid, and now everybody, because that test will be released in a couple of weeks, so now every lab should be in the position to test for anti-laminin beta 4 antibodies and to diagnose anti-P200 pemphigoid. So in the diagnosis of autoimmune blistering diseases, the clinical picture is essential, and direct immunofluorescence and serology are warranted in every patient, in particular in patients with chronic pruritus without any other cause, in patients for more than 70 years of age, to exclude Bullous pemphigoid, in patients with oral lesions of unknown cause, that could be mucous membrane pemphigoid or pemphigus vulgaris, and in all patients with conjunctival lesions compatible with mucous membrane pemphigoid. And then in every patient with mucous membrane pemphigoid, at least initially, anti-laminin CC2 reactivity should be tested for. And in my last topic, I told you that now with the assay for autoantibodies against laminin beta 4, we have a tool in hand to diagnose anti-P200 pemphigoid. And with this, I would like to thank the routine autoimmune team here at the Department of Dermatology. And I would like to remember now and shortly mention Delvaux. He was chair and professor of our department, and he suddenly died after short and severe disease in September last year. And he was not only the founder, but also the spiritual director of this autoimmune laboratory, and he has really always supported us and the development of new test systems. And we are very sad that he is not longer with us. Thank you for your attention.
Thank you very much. And also from my side, a warm welcome tonight in this webinar on blistering diseases. Professor Schmidt, this was really a wonderful overview. Not only did you show the clinical pictures of the subtypes of blistering diseases, but you also added some of the novelties. We have some questions in the chat here. So one of our dermatologists is asking, do you have additional tips to perform a good representative biopsy? He or she says, I know how to take the biopsy in the perilesional skin for immunofluorescence, and the biopsy for histopathology rather on the border of a blister. But do you have any extra, things to be cautious about?
Yes, I think, thank you for this question. I mean, it's a very practical one, and sometimes I also have a slide here, but I didn't include it. For the lesional biopsy, it's what you can really see is the level of split formation to differentiate pemphigoid from pemphigus disease. So you need part of the blister. So what is important that you biopsy the edge of a larger blister, that only half of the biopsy is actually covering the blister, and the other also covers the non-blistering disease. Because if you don't do that, the blister roof will go off in the biopsies, and then you lose it. And if you're too far from the blister, really, then you don't have any macroscopic, but also no microscopic blister, and then you only have the inflammatory infiltrate, and that doesn't help you even. You cannot even then differentiate pemphigus from pemphigoid diseases. And as you know, pemphigoid diseases, histopathology is not helpful to differentiate the different entities. So really, either you biopsy an entire very small vesicle or a larger blister, but 50% of non-blistering skin.
So that the transition is really appearing, yeah.
That's
good, yeah. I hope you stay indeed for the rest of the talk, because we will have some more practical questions. I would like to continue with the experience I have with sending samples to your lab in Lübeck. I can continue my slides here. One of our residents in Ghent has actually made a nice instruction on how to send samples. It can be either skin samples or serum samples to the lab of experimental dermatology in Lübeck. And you actually can send it to this address. We will definitely share this document with all the members, and we send it with just a simple B-post envelope. It can be sent on room temperature if you take serum, for instance, and the analysis costs about 100 euros to be paid by the patient, and the transport is about 16.5 euros is our experience. So you need to send serum, and he even wrote a quite clear instruction on how to obtain serum from a full blood sample, and preferably you send it in the beginning of the week, indicating the date of sending it. And the lab in Lübeck has actually provided a kind of request form where you can put all the clinical information, which is extremely important to really describe what you see clinically. And then you see what they offer, the direct immunofluorescence, indirect immunofluorescence, but definitely also the more rare ELISAs, and also, as we saw in his presentation, the immunoblotting. Because how else could we find a P200 pemphigoid? There is no ELISA for this, and you need this Western blotting to really have this coming out. So this is a very practical thing we will share with you. And just also to give you an overview, in Ghent we have quite a set of ELISAs. If we look at ELISAs and indirect immunofluorescence that you perform on a serum of patients. So we have the BP, the bullous pemphigoid ELISAs, we have the desmogleins, we also have the epidermal transglutaminase assays and also the collagen 7 assays. And what you might see, if I have a pointer, no, you don't have a pointer. No, what you see is that the ELISA testing is actually raising, so the demand for doing this test is really raising in our lab as well for bullous pemphigoid, but also for desmoglein testing. And you see that the indirect immunofluorescence is going down a bit. We don't have salt split skin in our hands, so we definitely come at a point where we want to send the samples to Lübeck and to really show maybe more specifically that we are dealing with a patient with a laminin 5 autoreactivity, for instance. So we do this quite often in diagnoses that don't come out, where all the testing in our hands is negative. And we are also aware of the fact that maybe you might not be aware of the fact that ELISA testing has obtained a reimbursement in Belgium since the 1st of April 2019. So you can ask if you are really looking at setting a diagnosis. So if you don't have a diagnosis yet, you can ask maximum 4 antibody tests twice a year to really obtain your diagnosis. And if you have your diagnosis and you want to follow up on how your treatment is doing, if your patient is really diminishing in autoantibody levels, then you can ask twice a year, maximum 2 antibodies. For instance, to see in a pemphigus foliaceus if your desmoglein 1 antibodies are going down. And so we do this quite often. It's reimbursed. It wasn't a few years ago, so you might want to be aware of this and do send out your samples. I see in the chat that you are asking to the society to provide a practical framework to perform these tests. And actually, I have the same question to the audience. Are you aware, when you send samples for desmoglein, where these tests are being done? Where are your samples sent to? Is your lab doing it? So please put in the chat if you know it is done in, I don't know, at UCL, or it's always sent to UGent, because we don't have a good overview of where the samples, the sample testing is done in Belgium. So together with the overview of Lübeck, I believe, and also with the form that we will provide to you, if you really have a case that you are struggling with, that we might come to a very good diagnostic. So my question is, how familiar are you with the ELISA serum tests? And I'm specifically asking about the ELISAs. Please put a 1 in the chat if you never ask them because you don't know which one to ask for which disease, or you use the most common ones like the ELISAs for anti-desmoglein or BP180, for instance, or you say, I know every ELISA available in Belgium, like the collagen 7 and the epidermal transglutaminase for During disease, you might also know. I see in the chat that one person is answering, I send sometimes samples to Groningen in the Netherlands, which is of course also a reference center for bullous disease. And yeah, of course, we've done that in the past as well. I see a 2. So I use the most common ones like ELISA, anti-desmoglein and BP180. I see most people replying this. I'm already very happy that no one says 1. So after this webinar, I hope you are aware of more testing possibilities and also some cases that you can send to Lübeck, for instance. Good. I will hand over the words to my co-chair, Cheyenne Delvaux, who will warm you up a bit further on a clinical case.
Thank you, Professor Lambert. Thank you. So I would like to thank Professor Ko for letting me present this clinical case that I saw during my fellowship in Avicenne in Paris, the French Referral Center of Autoimmune Bullous disease. This is a 67-year-old woman, and she has noticed since May 2022 buccal persistent erosions, red left eye, and dysphagia. She has diabetes, hypertension, and she takes insulin, Novonorm, metformin, atenolol, lansoprazole, and cetirizine. In the summer 2022, she saw 2 GPs and 1 otorhinolaryngologist, and they prescribed Augmentin and then prednisolone with an improvement with prednisolone, but a relapse when she stopped. In September 2022, she consulted an internist, and with the persistent buccal erosions and the red left eye, he suspected a Behçet disease and recommended to start colchicine. In October 2022, she was hospitalized in an internal medicine department for the same complaints, and she had lost 17 kilograms over the past 6 months and was very, very tired. So they performed some investigation. At the gastroscopy, they observed ulceration in the esophagus and decided to increase proton pump inhibitor. The PET-CT was normal and the HLA-B51 was negative. During her hospitalization, she developed an hepatic cytolysis, probably caused by colchicine, and they decided to switch to apremilast with an improvement. In December 2022, she finally arrived in the French Referral Center of Autoimmune Bullous disease. We performed a systematical anamnesis, and she had buccal persistent erosions, red left eye, dysphagia, crushed in the nose, but no cutaneous anal or genital lesion, which was confirmed by the examination. The ophthalmologist saw conjunctivitis and also 2 conjunctival ulcers, but no cicatricial lesions, so it was compatible with the non-cicatricial autoimmune bullous disease. With the stomatologist, we saw fibrinous ulcers on the lip and also on the tongue. At the fibroscopy, we observed crust in the nose, erosions in the pharynx, larynx, and also the rest of a blister on the epiglottis. So we performed some mucosal biopsy and serological tests. Histopathology of a mucosal biopsy showed acantholysis. Direct immunofluorescence of a mucosal biopsy was negative. Indirect immunofluorescence on monkey esophagus was positive, as you can see on this slide, with a reticular staining pattern fishnet-like. And the ELISA value was 123 for desmoglein 3. So we were a little bit embarrassed because it's recommended to make the diagnosis of pemphigus vulgaris on a positive direct immunofluorescence examination, so we performed a biopsy again, and the second direct immunofluorescence was positive with IgG deposits on the surface of epithelial keratinocytes. And we made the diagnosis of severe pemphigus vulgaris with buccal, nasal, laryngeal, esophageal, and ocular involvement. We started the treatment with 2 infusions of rituximab, 1 gram 2 weeks apart, associated with oral prednisone, 1 milligram per kilo per day, and local treatments. And 1 month after the first infusion of rituximab, we saw an improvement, but the persistence of some oral and nasal lesions. To conclude, I decided to show you this case because it demonstrates the ignorance of the autoimmune bullous disease in the medical world. There is often a long delay between the onset of symptoms and the diagnosis, particularly when there is no cutaneous involvement. Sometimes, even in referral center, you can get difficulties to have positive direct immunofluorescence, so don't hesitate to repeat the biopsy. And as an introduction to the second part of this session, it was interesting to see a small improvement with apremilast, which could be a future treatment for pemphigus vulgaris, and maybe Professor Schmidt will tell us more about it later. And maybe we can directly move to the second part of this session?
Or there is a question in the chat,
perfect,
which relates to still the diagnostic part, and it's a question for Professor Schmidt. And it's also in your case, the direct immunofluorescence is sometimes negative, especially in patients that are already under immunosuppressive therapy. So does it make sense to still do a biopsy when someone is already under immunosuppressive therapy? And also, would you then biopsy a rather young lesion or an older lesion, or doesn't it matter at all? The life of a lesion, it's actually, yeah.
Right. Shall I answer or is,
Yeah.
Yeah, so I think if you have still active lesions, irrespective of any treatment, I mean, as we know that the autoantibodies are directly pathogenic, you need to suspect that the autoantibodies are still there. So even if you're under immunosuppressive treatment, it's worthwhile taking a direct immunofluorescence. And then you take it perilesional, and there it doesn't really matter if it's a new lesion or if it's a perilesional to an older lesion. But of course, if you have the choice, I would always go for the new lesions. But in theory, I mean, nobody really systematically looked to that. The autoantibodies should be everywhere. But I would go for the newest lesions, perilesional, but even under immunosuppressed, that doesn't matter.
Okay, good. Thank you. I think it's time to move to the second part, which will indeed be more on treatment. And we have chosen to show you or to go through the guidelines that were made, amongst others, by Professor Schmidt with the Bullous group from the EADV. And here it is. So we have chosen to go for to show the guidelines, the European guidelines for handling pemphigus, and then my colleague will show you the guidelines for bullous pemphigoid. They start actually with what should you take up from the medical history. These are, of course, symptoms, but also do a systematic screening, like hematological, oncologic. You have heard the reasons why. Also ask about pregnancy wish, because this will also influence what you do as a treatment. And definitely also look at which drugs the patients are taking, because a drug-induced bullous disease is definitely also something that we see. Update the vaccinations. So PV, PF, we have kind of positioned it here. The workup you have to do before starting systemic treatment is quite obvious. Maybe definitely also do a hepatitis serology and also HIV, but also some glycemia, because you might want to start the corticosteroids and you want to know if a patient was diabetic before already or not. Good. What I see that is often used in the guideline is a classification between mild and more severe bullous disease, and they base themselves on an instrument which is called the PDI, the pemphigus disease severity instrument, so to speak, so this pemphigus disease area index, an assessment of severity. I think it's quite complicated and I don't use it in clinical practice. But then you know where the moderate and mild disease comes from when you look at the publication. And so there is indeed moderate, significant and extensive disease, and they come up with a treatment algorithm for mild pemphigus foliaceus, for instance, and first-line treatments are here dapsone or topical corticosteroids and systemic corticosteroids at a dose that you can read. And I was a bit surprised that rituximab is also already put as a first-line treatment, but then in the second line you see that rituximab is also coming back, which is probably more the position I would also put it next to systemic corticosteroids. If disease control is achieved, you still have to continue. If not achieved, you can combine rituximab and prednisone, for instance, or even other immunosuppressants. We come back to that. The same for mild pemphigus vulgaris. First line there, rituximab really comes a bit more to the foreground because rituximab is proven to work very well in pemphigus vulgaris. The typical dose that is given also in the severe form is 2 infusions of 1 gram 2 weeks apart. And you might combine it in the beginning with some prednisone, but to really taper it down quite rapidly after rituximab is really obtaining its clinical or therapeutic effect. So rituximab, definitely ask or put your patients on that, probably in a hospital environment because it's to be administered in a day clinic. Okay, but then let me come to moderate to severe as well, PF, SPV. First line treatment, again, rituximab or systemic corticosteroids alone or associated with azathioprine or mycophenolate, 2 grams a day, which is also a possibility. And then comes how to move on. You might say, I start with rituximab, and then what you have to do is, of course, look at disease control. And what typically is done, that there is a second round of infusions at month 6. And then you monitor with the desmoglein titers whether a patient really goes into remission or not. And typically you look then if a month 12 and 18 infusion is needed. But here it is recommended to still continue it even if a patient has no longer the anti-desmoglein antibodies. So maintenance at month 12 and 18, but then at a bit a lower dose than at the initiation of the treatment. CIVARS is the system where you have to ask for reimbursement for for rituximab, and you open CIVARS. If you put in rituximab, you will not, the system will not find the drug, which is quite weird because there are biosimilars available already of rituximab. So you really have to type in MAPTERA, which is what I did here. And then you can choose the dose, which is the 500 milligram solution that you have to ask for, like here. And also in the next step, then you indicate that your patient has a severe immune disease, which is really influencing the prognosis of life, which is also something you have to type in. And then in a second time, you have to indicate it's a severe immune disease. And it's quite easy. Then if you click, you kind of have a reimbursement for life, I have the impression. So it's quite easy and straightforward to ask for reimbursement, and the hospital pharmacy can see that your patient has the right to have rituximab. So maintenance, a question for Professor Schmidt I have. What is your policy for maintaining rituximab treatment after month 18? So the guideline goes until month 18. Would you then stop if your patient no longer has autoantibodies, or do you look at only at the clinics, or do you use a cutoff ELISA value of desmogleins?
Yeah, thank you very much. I think that's a very, very important and clinically relevant question. But also the guidelines give you different options, really. So they're the physicians that give another infusion of rituximab at month 6, and then month 12 and month 18. That is one fraction. And this is maybe done especially in patients that have very high desmoglein 3 levels at the time of diagnosis, or that have already desmoglein 3 high levels at month 3 of the diagnosis. And then there is the fraction that only give another dose of rituximab if there's not complete remission. And what we do really, if the patient after the initial 2 gram of rituximab comes into remission, we wait until the autoantibodies go up again. And before then, actually, the clinical relapse occurs, then we give rituximab. So we regularly monitor the autoantibody levels. And then that's what we do. But we are not the people that give maintenance treatment without any clinical lesions.
Yeah. I would agree. We do the same. Otherwise, you have the feeling you are over-treating, and then there's another situation where sometimes you still have high titers, but never a clinical problem. So those are then probably the non-pathogenic antidesmogleins, and difficult,
Yes.
no?
Yeah, that's true. And we have patients with pemphigus vulgaris, I would say maybe 10 to 20% that have persistently high desmoglein 3 autoantibody levels. Obviously, they may not be pathogenic. Maybe it's a different subclass, IgG subclass, or it's a different epitope that's not so pathogenically relevant. But in these, it's more difficult. And here, I would recommend to clinically monitor the patient. I mean, most of the patients, they are not too old. You can tell them. So if you have anything in the mouth that comes back, if you see any lesion on your body, then call and then we treat early. But that's what we do.
Yeah, fully agree. Thank you very much. Last slide on my guidelines is if a patient cannot have rituximab for one or another reason, there are of course the options of azathioprine still and mycophenolate up to 2 grams a day. The guideline says methotrexate or cyclosporin are not recommended. Well, sometimes we tend to still give methotrexate, but so there are definitely better options for pemphigus. I will move on to bullous pemphigoid and hand over.
Yes, thank you. So I will now present the European guidelines for handling bullous pemphigoid, published in the GADV in 2022. I will begin with a focus on the BPDAI, so the Bullous Pemphigoid Disease Area Index. And like the Pemphigus Disease Area Index, there are 2 separate scores for skin and for mucous membranes activity, even though it's relatively rare to have mucous membrane involvement in PB. So for the skin involvement, you have 2 columns, the first one for erosions and blisters, and the second one for eczematous and urticarial lesions, and a small third column for potential damage, such as pigmentation, and the total score can range between 0 and 360. Let's start with mild and moderate BP, defined with a BPDAI score less than 20 and between 20 and 57 respectively. The first choice is to apply superpotent topical corticosteroid once or twice a day. As you know, we are talking about clobetasol propionate, 0.05% cream, between 20 and 30 mg per day, on whole body, including both normal skin and skin with blisters and erosion, except the face, until control of disease activity. And when control of disease activity is achieved, you can perform a tapering schedule, as you can see on this slide. The first option is oral corticosteroid. We know that high-dose corticosteroid therapy, 1 mg per kilo per day, is effective, but it's also associated with a higher mortality and increased side effects compared to the topical therapy. So, it's recommended to start with an initial dose of 0.5 mg per kilo per day, prednisone or prednisolone, and you can perform a dose reduction 2 weeks after disease control and a tapering schedule during 4 months. You can continue with the maintenance treatment with prednisone 0.1 mg per kilo per day for 3 to 6 months and try to stop. But before discontinuing treatment, it may be considered to perform an ELISA BP 180, and if the ELISA value is lower than 23 IU per milliliter, there is a 90% probability of non-relapse. Doxycycline and dapsone may also be considered as a second choice, most often in combination with topical corticosteroids. Let's move to severe BP, defined with the BPDAI score above 57 or more than 10 new blisters per day. First choice is to apply super potent topical corticosteroids twice or once a day, and the rules are similar than for moderate and mild BP. The only change is the quantity of cream. Here you have to use 30 or 40 milligrams per day. The second first option is oral corticosteroids at an initial dose of 0.5 mg per kilo per day prednisone, and at a later stage, in patients not responding to this regimen, you can increase the oral prednisone or add topical corticosteroids. In patients who have multiple relapses during tapering schedule of a corticosteroid, you can add a conventional immunosuppressive drug such as methotrexate, mycophenolate mofetil, or azathioprine. And in patients in poor general condition or in those with contraindication to immunosuppressive drug, you can try with doxycycline, dapsone, and omalizumab, but remember, be very, very careful if you prescribe dapsone in the elderly. In the case of patients who remain unresponsive despite several weeks of intensive therapy, you may add a conventional immunosuppressive drug, methotrexate, mycophenolate, and azathioprine, or try other therapeutic options without any prioritization in this list. You have rituximab, omalizumab, dupilumab, and intravenous immunoglobulins. So to conclude, the difficulty for me to treat a BP is to avoid being too iatrogenic with our treatments in patients who are often elderly, fragile, and with multiple comorbidities. And maybe I can ask the first question to Professor Schmidt. I was a little bit surprised when I saw rituximab in the same list than dupilumab and omalizumab. Don't you think there are too much risk to give rituximab to the elderly compared to safer drugs such as dupi and omalizumab?
Thank you very much. I mean, that's a good question, of course. And the problem is that with rituximab, yes, we have it in the elderly, but also what is also bothering us, that it's not as effective as in pemphigus. We know in pemphigus, I mean, 80 to 90% of the patients benefit from rituximab. And this, I mean, there's of course no controlled clinical trial with rituximab and bullous pemphigoid, but we and others have the impression that that is much lower, maybe 50 to 70% really benefit from that. So we are also a little bit reluctant to use rituximab. So that is really then maybe our third line therapy. We start bullous pemphigoid with prednisolone, 0.5 milligram plus dapsone. If that is our contraindication, if that is a contraindication or not working, we give azathioprine, and then maybe at the third line, if possible, rituximab, and if not, then we give IVIG.
Yeah. Thank you. Do you have other question for?
Well, maybe I can add one. Maybe I can add one thing, that these scores that you're mentioning, I think they're quite relevant, also clinical relevant. So in all our patients, we do in pemphigus, we do the PDAI score, and in bullous pemphigoid, the BPDAI score. And we always do that in the patient is submitted on the ward, and then if the patient is discharged. And then we also do it in every follow-up. And it's a little bit complicated, maybe if the patient has a lot of lesions, but in follow-up, usually the patients have few lesions, and that's really, really fast. And that also shows, if you get, for example, off-license treatment, how the patient has responded to that. And even if there's not complete remission, you can still follow up on these scores and say, okay, 90% reduction or 80% reduction. So that in our hands helped a lot to get the reimbursement.
Thank you.
Yes, there is someone challenging. Is there really someone that achieves resolution with topical corticosteroids alone? And that's then, I guess, for bullous pemphigoid. Is it possible not to go to systemics? Is that a minority of patients, or? So your experience, Professor Schmidt, with only topicals for bullous pemphigoid?
I mean, there are different schools. I mean, and in the New England Journal paper by Pascal Joly and the French group Bullous, they have basically shown that 0.5 milligram prednisolone is as good as 40 gram of super potent topical corticosteroids. But the misunderstanding, in my opinion, is always that people think that these topical steroids are less associated with less adverse events or with higher efficacy than 0.5 milligram prednisolone, but they are not. What they have shown is that if you start with 1 milligram prednisolone in bullous pemphigoid and then compare with the topical treatment, then mortality is higher, severe adverse events are higher. But so we always combine our topical steroids in moderate and severe bullous pemphigoid with systemic therapy. And only in mild bullous pemphigoid, we use only topical corticosteroids, but also usually then combined with either doxycycline or dapsone, because this week's treatment of topical steroids is quite impractical.
Mm-hmm. Yeah, a lot of questions on the newer treatments. Omalizumab is definitely not reimbursed in our country for bullous pemphigoid, but I guess it would be a good choice. But then another question is, what about nicotinamide? Do you use it as an anti-inflammatory, rather soft systemic? Nicotinamide?
Yes, I mean, these questions are coming up quite frequently. Nicotinamide has been traditionally combined with tetracyclines, but there was a study in The Lancet, a prospective controlled trial with more than 250 bullous pemphigoid patients where actually systemic corticosteroids were compared with doxycycline. But in this study, no nicotinamide was used. And there in this study was shown that actually doxycycline is also effective in bullous pemphigoid. So I think most of the people they use, if they want to use tetracyclines, they choose doxycycline and without this nicotinamide. But I mean, you can add nicotinamide. I think there are very, very few adverse events on that, but we have not used it for more than 10 years, I would say.
Okay, very clear. Thank you. I believe.
Yeah, maybe the question on omalizumab.
Yeah.
I mean, there are some nice data in case series and also in individual patient. But there was actually a randomized controlled trial by Novartis that was stopped in 2014 and still unpublished. And there was no difference actually between the omalizumab group and the placebo or standard therapy group in bullous pemphigoid. So that Novartis is not following up. So I think that should be really reserved to individual patients and after really a lot of thinking, because evidence is not there really.
Super, that's very clear. I will hand over to my colleague to introduce another case.
Yes, it's now my pleasure to introduce Dr. Loraine Combemale, a last year resident in Saint-Pierre, and she will tell us more about lichen planus pemphigoid. The audience is yours, Loraine. We don't hear you. Maybe you can try again? Yes, so we have a little problem, technical problem.
I think you're just... You have to unmute yourself.
I know, she says.
Okay, can you hear me now?
Super,
Yes.
yeah.
Yeah, I didn't have access, sorry. So, good evening. I would like to thank Professor Lambert, Dr. Delvaux, and Professor Delmamon for inviting me to present my work on lichen planus pemphigoides. So I'm going to talk briefly about lichen planus pemphigoides and a series of 12 patients. And a series of 12 patients with lichen planus pemphigoides with predominant mucosal involvement. This work was carried out with the dermatology team of Avicenne Hospital in Paris, which is the National Reference Center for Autoimmune Bullous Disease. And I would like to thank Professor Co, Professor Prof, Dr. Leroux, and Dr. Bolle, who worked with me. So, lichen planus pemphigoides was defined first by Capozzi in the 19th century as an association of lichen planus and bullous pemphigoides. It is a rare autoimmune bullous disease of the pemphigoid group that presents both clinical and histopathological features of those diseases. The autoimmune character is demonstrated by a linear deposit of autoantibodies at the dermal epidermal junction on direct immunofluorescence. The treatment is the same as bullous pemphigoides. Mucosal involvement have been rarely reported, and cases with mucosal predominance are even more rare. We described a series of 12 patients with predominant mucosal involvement, which are either mucosal involvement without skin involvement or more than 2 mucosal sites involved in addition to skin involvement. This is a retrospective monocentric study conducted at Avicenne Hospital between 2001 and 2019 using the National Reference Center database. We observed 3 categories of lesions. So the first category, you can see typical lesion from the autoimmune bullous disease. We can see a blister on the skin, typical of bullous pemphigoides, and a blister around mucosa, typical of mucous membrane pemphigoides. We observed also typical lesion from lichen planus. Here, papules on the skin and typical lichenoid network in the mouth. Finally, we observed a last category of lesions that were not very much described in the literature, and we called it a specific lesion because we couldn't tell if it was because of the lichen planus or the autoimmune bullous disease. Here you can see atrophy, synesthesia, erosion, and erythema. Our study on lichen planus pemphigoides with mucosal involvement suggests that there is an existence of a broader spectrum more than a simple association of lichen planus and bullous pemphigoides. We observed in our study and in the literature a quite long diagnostic delay that we try to explain first by the fact that usually lichen planus lesion will appear first and then blisters will appear. Also, because of this category of aspecific lesions, which makes the clinic more difficult. In fact, numerous biopsies are necessary to obtain the diagnostic, and you should not hesitate to repeat it. We observed a good response and good control of the disease when patients were treated with dapsone. And this clinical form with mucosal involvement is more difficult to treat than the pure cutaneous form. Thank you for listening.
Thank you, Loraine.
Maybe we can have some comments from Professor Schmidt on this entity. And can lichen planus also give positive BP180 ELISAs, for instance?
Yes, thank you. That was a very nice case, and I mean what we think is really happening here that by this interface dermatitis by lichen planus, there are these target engines, in particular BB180, is exposed in some way to the immune system and some kind of immune reaction, and the loss of tolerance against BB180 is initiated. And then what is really specific for most of these cases that autoantibodies are directed against the NC16A domain of BB180. And some years ago, we classified lichen planus pemphigoides as a proper entity, but we now understand it more like lichen planus to be a trigger of this autoimmune blistering disease. And there are also other triggers like psoriasis also described. But right, I mean, BB180 and C16A ELISAs should be positive, but there are very few patients that also are unreactive and they react with the C terminus of BB180.
Okay, okay. Thank you. Before I go to a question to you on which next therapies and what's in the pipeline, I have two more practical questions from the chat. So going back to rituximab for pemphigus, if you then retreat upon ELISA titers raising again, would you then go for the full twice 1 gram with 2 weeks apart, or only once 500 milligram, or is that depending on the severity?
Yeah, I think the guidelines are not too clear here, and also the German guidelines don't give real responses because we don't have data. So what we usually do is that if it's only the autoantibody that is going up, then we give another gram, just 1 gram. But if there's a proper relapse, then we restart. We give 2 times 1 gram, and usually we also reinitiate then or reinitiate the prednisolone.
Okay, and then a last practical question. How often in your experience does a pemphigus foliaceus go into remission with dapsone? So your experience with this dapsone? Or is it an older drug that you don't use anymore? Or?
I think we don't really use it, but I mean, this guideline, I mean, there are 30 authors and we finally voted on that. And this is kind of democracy, and a lot of people, they like it, and I'm sure there's some things in it. Of course, there's no clinical study, and because it's not really too dangerous, people use it. But we all know that you cannot really bring pemphigus foliaceus into complete remission with dapsone. So in Lübeck, we're not using it.
No. Yeah. Okay. I will go back to the slides.
For pemphigus foliaceus, I mean.
Yeah. Okay. I will go back to the slides now. Some question: which next therapies can we expect, and when? What is in the pipeline, and what is promising? Maybe. I found this article from your group, and it's very small, but we do see some, pathogenesis turned into kind of targets for new compounds like the Bruton kinases in pemphigus, and also in Bullous pemphigoid we see some new approaches. Also, by the way, ixekizumab for psoriasis, but here used or tested for Bullous pemphigoid. Can you comment on any of the first results of these studies?
Yes, I mean, I can comment on that. So I think that the most serious, the ones above are for pemphigus, and the most serious and most advanced is really the one with the FcN inhibitor. That is here the
the argenx,
ARG3. We don't say any companies here. So this the number 3 there, and that there's no data published, but there's a promising phase 2 study, and the trial, all patients have been included, and so all patients in, but not all patients out, and the data will be expected, the first clinical data, around January, February. Okay, then the fourth one, really, the BTK inhibitor that has been stopped, the primary endpoint not met, very disappointed. And although the phase 2 study was really good, and all the other ones here, I mean, the last one is on hold, and ofatumumab and this BAF inhibitor, that is something very small, single center, and not supported by industry. So that is not a study that lead to the license. So the only thing that is actually running in pemphigus that may, if there are positive results and if the primary endpoint is set and if there's no safety issue, may go to licensing, is the third one there, the FcN inhibitor, efgartigimod.
Okay.
And the second one, for the bullous pemphigoid, there are actually 3 trials that go for licensing of the drug. One is also here. That is the, actually none is here really. There are 3 drugs. That is dupilumab, that is trialed in the moment. Recruiting is so going on, not too bad, not too good. Then we also have efgartigimod. That is, I mean, the FcN inhibitor that just started. So the recruiting is quite going well. And then we have benralizumab, that is not here. Benralizumab is an anti-interleukin 5 receptor inhibitor. That's also a company sponsored phase 3 trial that, if we are lucky, will go to licensing. All the others here, ixekizumab, NPB1, AC2003, bertelimumab, rituximab, that are investigator-initiated trials. I mean, we're all looking forward, but they will not lead to licensing of anything.
Okay. Thank you. Okay, that's some hope for the future and for difficult diseases. And good, I believe, Cheyenne, that we are coming to the end.
Yeah.
And learnings of the evenings, I put it a bit visual. Several entities in bullous diseases, also lots of antigens that can be detected in a general lab or in more specialized labs like the one from Professor Schmidt in Lübeck. You now know how to send samples. And then we also heard about I would say existing drugs, but also upcoming drugs, because the pathogenesis is becoming more and more known in these diseases. And so leaves me to thank very much our expert for having taught us several things on blistering disease. We could go on for several hours. I'm sure it's a very interesting area, but I think we have to close here. Thank you very much to you as an audience. Our next webinar of the Society will be on alopecia areata for the fall, typically the last Thursday of November, and this will be the 23rd of November. So thanks so much for attending this webinar, and have a good summer, all of you. Thank you.
Thank you.